Good afternoon, dear students. Today we should speak about a very important topic, changes of the eye fundus in general diseases. Today we concentrate on arterial hypertension, diabetes mellitus, pathology of the kidneys, blood diseases, and pregnant toxicosis. To tell the truth, this information will be very important not just for ophthalmologists but also for GP and to the doctors of other specialties. So I would like to ask you to pay attention on this information. On this picture, you can see the normal eye fundus, which we can see during ophthalmoscopy. This is the disc of the optic nerve. This is the central part of the retina macular area. These are the vessels. This is vein. This is artery. Artery usually thinner than vein. It's known that the vessels of the retina have cerebral origin and have the same peculiarities. Vascular changes of the retina are interesting not only for ophthalmologists but also for neurologists and GP. This ophthalmologic picture helps to make conclusion about the condition of the cerebral vessels and the whole vascular system. We start from the arterial hypertension. Changes of the eye fundus in arterial hypertension include four stages. The first stage, hypertensive angiospasm or angiopathy. This angiospasm is characterized by the constriction of the artery along the whole retinal surface without organic changes in arterial wall. The most characteristic feature is the twisting of artery and veins. In the literature, the twisting of the small arterial and venous vessels is called by the name of the author, Grist symptom. In this uh, in this stage, the visual acuity is rather good, and visual function doesn't uh, doesn't decrease. On this picture, you can see the examples of the first stage, a hypertensive angiospasm or angiopathy. You can see just constriction of the arteries. The second stage, hypertensive angiosclerosis. In this stage, we can see anatomical changes of the vessel system. As in the first stage, we can see just physiological changes, just spasm. First stage is the organic changes. In this stage, the symptoms of Cooper and Silvers Y appears in addition to changes from the first stage. The symptom is manifested by the thickening of arterial wall and deposition of cholesterol in it. There are also obliteration of small arterial vessels. In this stage, the arteriovenous chiasms appear. They were called by the name of ophthalmologists Salus and Gunn, who was the first who described this symptom. The symptoms of arteriovenous chiasm point out the severe changes in venous system, occurrence of venous stasis in different degree. On this stage, you can see organic changes in the vessels. In some cases, we see small hemorrhages. And now we should discuss the symptoms of salus and gund, which is characterized the second stage of um, hypertensive um, changes of the fundus of the eye in anterior um, hypertension. The first degree, the vein in the place of chiasm constricts and venous phenomena of venostasis are observed in the distal part. The second degree, the vein constricts some more near the place of chiasm with the artery, conical constriction. Characteristic feature is the occurrence of venous arc. The veins are plethoric, dilated. The phenomenon of stasis are accompanied with small bleedings along the passage of vessels. The third degree, the vein in the place of chiasm with the artery is interrupted. We can see the picture of microthrombosis, bleedings, and you can see the picture of hypertensive angiosclerosis. And fourth degree uh, of the symptoms of salus and gund as a result of previous vascular changes, edema occur on the retina. The visual function in this stage usually also rather good. If the edema and hemorrhage are localized in the central macula, the patient may um, have decreased visual function. But usually, also in this stage, the visual functions are good. Again, you can see the picture of angiosclerosis. You can see examples. This is salus gund symptom where we can see that vein looks interrupted. Okay, we should go further. The third stage of the hypertensive retinopathy is the stage of hypertensive retinopathy. In this stage, we can see in the retina hemorrhages and edema, not just small hemorrhages like in a stage of angiosclerosis, but big hemorrhage and big edema. Look on this picture, you can see hemorrhages, edema, and the fourth stage of the hypertensive retinopathy is a stage of neuropathy. In this stage, um, the process is spreading from the retina to the optic nerve, and this is a severe stage, and we can see during examination of the patient that the disc of the optic nerve becomes edematosis, red, increase in sight, and we can see the hemorrhage around the disc. And when we see such picture, we should say that it's a very severe arterial hypertension. Look on this picture, you can see changes not only in the retina but also in the optic disc. You can see edema of the optic disc, optic nerve disc. You can see how to this disc prominent in a vitreous body. Here also hemorrhage, edema, the vessels, mm, the vessel dilated. Look again the examples. You can see here the changes on the retina, but also you can see changes in the optic disc. You even can see the borders of the optic disc. In this stage, visual functions, of course, are affected. Visual acuity decrease, visual fields are constricted. Uh, we can see different scotoma. Look, very severe picture. Okay, so we have already finished um, discussion of the changes of the eye fundus in arterial hypertension, and now we should speak about changes of the eye fundus in diabetes mellitus. I think that diabetes mellitus nowadays like an non-infection epidemic. More and more people suffer from diabetes mellitus, and 90% of the diabetic patients have problem with the retina, have changes in the retina. And in Western country, diabetic retinopathy is the leading cause of blindness and visual disability. Let's discuss the factors influencing on diabetic retinopathy. The first, duration of diabetes, of course. Types of diabetes mellitus. Usually, um, we can observe diabetic retinopathy rather often in females than in male. Arterial hypertension, glucose level compensation. Of course, if we see normal normal compensation, the risk of the diabetic retinopathy decreased. What happens in a retina in case of diabetic retinopathy? This on this picture you can see healthy retinal capillary. These are capillaries in diabetic retinopathy. Some capillaries closed, some dilated, and we see like a microaneurysm. And here you can see that area is not receive nutrition. This area are ischemic area, and this ischemic area produced vascular endothelial growth factor, and this factor is the main impulse for neovascularization and macular edema. Rather difficult way, but you should remember just in general. Okay, we just revise pathogenesis of diabetic retinopathy, and now we should speak about clinical manifestation of diabetic retinopathy. Classification. We have two stages, non-proliferative and proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy is characterized by microaneurysm, retinal hemorrhages, hard exudates, retinal edema, cotton wool spot, venous abnormalities, bleeding, looping and dilatation, and intraretinal microvascular abnormalities. On this picture, you can see examples of non-proliferative diabetic retinopathy. You can see here hemorrhages, you can see heart exudates, the same. heart exudates, hemorrhages. What? Some more examples of the fundus of the eye. You can see again hemorrhages. You can see how looks vein dilated. Here you can see hemorrhages, microaneurysm. Again, hemorrhages, heart exudates, cotton wool exudates. A lot of hemorrhages. This picture you can see heart exudates, some hemorrhages. This is the central part of the retina, edema, exudates, cotton wool spots. Again, okay. Proliferative diabetic retinopathy is characterized by the appearance of neurovascularization. Uh, and we can also see vitreal hemorrhages. So, neovascularization of the retina and vitreous hemorrhages are the main signs of proliferative diabetic retinopathy. Look, look on this example. You even can't see the optic nerve. Here you can see proliferative tissue. And I will show you some pictures. Look, proliferative tissue. Again, here optic nerve, but you can see new vessels and proliferative membrane. Here also, we can just think that something here must be the optic nerve, and here you can see proliferative tissue directly in the center of the macular area, and this is a very severe situation. We can suggest that this patient has rather bad visual functions. Again, vitreous hemorrhages, that's why we can't see fundus properly. Again, proliferative tissue near the optic nerve, big hemorrhage. Here you can see the big hemorrhage from new vessels, very severe situation because this hemorrhage is affected the macula, the central area, and the patient in this situation can't see in the center. Mhm. I have already mentioned that 90% of the people with diabetes mellitus have diabetic retinopathy. That's why the treatment, uh, management, diagnostic of the diabetic retinopathy is very important. If in the case of arterial hypertension, we should just to control um, arterial hypertension to stop hypertensive retinopathy. In the case of diabetic retinopathy, we should treat such patient aggressively. So, of course, in the treatment of diabetic retinopathy, the first place strict metabolic control of blood glucose and other other metabolic disorders. Um, if the second place, it's a photocoagulation of the ischemic areas. Third place is a surgical treatment when we see the severe proliferative retinopathy, uh, when we see vitreous hemorrhages. Rather new treatment, anti-VEGF therapy, when we inject mm, some medicine directly in a vitreous body. Of course, metabolic therapy, when we add different vitamins and other medicines which can improve the nutrition of the retina. Mm. I would like to show you some pictures. Here you can see the edema of the macular area. Here you can see laser coagulation. Oh, on this picture you can see the examples of the fluorescent angiography, which is one of the most important methods of diagnostic diabetic retinopathy. This method help us to diagnose diabetic retinopathy mm, if there is proliferation or not, and we can check the effect mm, laser coagulation, previous laser coagulation, and if it's necessary, maybe to add coagulate or we should stop the coagulation. Also, we can see the severity of the macular edema. No, to tell the truth, when we receive the inhibitors of vascular endothelial growth factor, the effectiveness of the treatment of diabetic retinopathy improve. These anti-VEGF medicines help us to decrease neovascularization, to decrease macular edema. On these pictures, you can see it just without contrast. It's also without contrast, just black and white picture. And here you can see the picture when we inject the contrast fluorescent angiography. Okay, so now we should discuss the changes of the eye fundus in the kidney diseases. But before we start, I would like again to pay attention that you should examine patient with diabetic mellitus very carefully. If you, for example, GP and patient doesn't have any problem with the vision, you should every year send such patient to ophthalmologist. If the patient has the problems with the vision uh, or has non-proliferative diabetic retinopathy, every 3 6 months you should send such patient to ophthalmologist, or if the ophthalmologist maybe prescribe mm, mm, another dates. So don't forget about diabetic retinopathy and try to send such patient to ophthalmologist in time. Um, because we should save to the patient his vision, and nowadays we have opportunity to save vision to our patient with diabetic mellitus. Laser coagulation, anti-VEGF therapy will help will help us mm, to save vision to this patient. Okay, so we should go further. Changes of the eye fundus in a kidney diseases. The most frequent changes of the eye fundus are observed in chronic nephritis. In the beginning of the process, the changes of the retina arteries are observed that refers to the first stage of retinopathy. In the advanced cases, sclerotic changes are found. This picture is much more severe than the picture of hypertensive retinopathy. In addition to sclerotic changes in the retinovascular system, a profuse exudation appears. The developed stage of retinopathy is characterized by the constriction of vessels, arteries and veins becomes of equal caliber. Besides the edema of the whole surface of retina, bleedings occur mainly in peripheral zones. In the central part of the retina, in macular area, we can see the exudates looking like a star. But look on these pictures, you can see different soft exudates, hemorrhage, and in macular area we can see the star. And this is the typical picture for kidneys retinopathy. In progression of kidneys retinopathy, the disc of the optic nerve also is involved in the process. During ophthalmoscopy, we can see that the disc of the optic nerve uh, is edematosis. We can see the great edema of the optic nerve. Also, we can see a lot of hemorrhage on the surface of the retina. The stage of retinopathy and neuroretinopathy correspond to the severe clinical manifestation in the kidneys. Look on this picture. You can see changes in vessels. You can see the star in the macular area, and you can see edema on the disc of the optic nerve. If you see such patient with a severe kidney retinopathy, you should immediately send such patient to GP. Okay, so we should discuss the changes of the for eye fundus in rheumatism. Uh, Usually, in inflammatory systemic diseases, we can see inflammation of the uveal tract, vascular changes, vasculitis, and perivasculitis often appear in rheumatic patients. During ophthalmoscopy, we can see the appearance of small perivascular moves, occurrence of exudates of the blood-formed elements in the retinal tissue. Inflammatory process may spread over the whole vessel and cause severe panvasculitis. So we should discuss the changes of the fundus of the eye in blood diseases. No, at first we should speak about leukem- leukemic retinopathy. Leukemic retinopathy is characterized by the pale and orange fundus background with the dilated veins. In later stages, grayish-white lines may be seen along the course of the vein. Arterioles become pale and narrow. Retinal hemorrhages with a white center are very common. But look, on this picture, this is a typical picture of the leukemic retinopathy, especially retinal hemorrhages with white center. Anemic retinopathy rather often appear in patients with a low hemoglobin. In anemia, retinal changes usually occur when hemoglobin levels falls by 50% and and consistently present when below 35%. Anemic retinopathy is characterized by pale arteriosis and pale general background of the fundus of the eye. Retinal veins are dilated. Superficial retinal and parietal hemorrhages may be seen. Look, pale, pale fundus. And in the end of the lecture, we should discuss changes of the eye fundus in pregnancy toxicosis. Um, in other literature, you can see the name of this disease, toxemia of pregnancy, pregnancy-induced hypertension. Pregnancy-induced hypertension is more often we can see in English literature. So a lot of the names, but it is the same diseases when we see in a pregnant woman, we see arterial hypertension and edema and changes in the vascular system. One of the first scientists who studied the fundus of the eye in pregnant women was Liebert. In 1859, he called the affection of the retina in pregnancy albuminuritic retinitis. In 1979, Hawking was one of the first scientists reported his opinion that ophthalmoscopic changes of the retina in albuminuritic retinas are connected with the damage of vascular system. Now, some words about the cause of the changes um, in the retinal vascular system. Pregnancy, usually we call that it's not a disease, but in some cases, pregnancy-induced hypertension is a disease of unknown etiology, characterized by raised blood pressure, proteinuria, and generalized edema. Retinal changes are liable to occur in the condition when blood pressure rises above 160 over, over 100 and are marked when blood pressure rises above 200 over 130. Um, Rather often, the specialist gynecologists and obstetrics ask to ophthalmologists to watch the fundus of the eye because we have already mentioned that the changes um, of the retina vessels correlate with the changes of the um, mm, brain vessels and heart vessels. Early changes consist of narrowing of the nasal arterioles, followed by generalized narrowing. Severe persistent spasm of vessels causes retinal hypoxia, characterized by appearance of cotton wool spots and superficial hemorrhages. If pregnancy is allowed to continue, further progression of retinopathy occurs rapidly. Retinal edema and exudation is usually marked and may be associated with macular star, like in a kidney retinopathy. In the severe cases, we can see flat macular detachment. Rarely, it may be complicated by bilateral exudative retinal detachment. What should we do in a retinopathy in a pregnancy, including hypertension? Changes in a retina usually are reversible and disappear after the delivery, unless organic vascular disease is established. In pre-organic stage, when patients respond well to conservative treatment, the pregnancy may justify be continued under close observation. However, the advent of hypoxic retinopathy, when we see the soft exudates, retinal edema, and hemorrhages, should be considered as indication for termination of pregnancy. Otherwise, permanent vision loss or even loss of life of both mother and baby may occur. I would like to thank you for your attention. I hope this lecture will be useful for you in your general practice. Hope to see you in our classes, in our practical classes, and we will continue to see the uh, pictures of the eye photos and discuss ophthalmological problems. Thank you and goodbye.
Good morning, dear students. Today we should continue our ophthalmological lectures. Our topic today is diseases of the retina and optic nerve. I hope you know that retina and optic nerve is the most important parts of the eyeball. The optic nerve is about 45-50 millimeters, and we can divide optic nerve into 4 parts: intraocular 1 millimeters, intraorbital 30 millimeters, intracanalicular 6-9 millimeters, and intracranial parts. There are shades of the optic nerve: dura, arachnoid, and pia mater. On this picture, you can see the main groups of diseases of the optic nerve. It's inflammatory diseases, papilla edema, tumors, and diseases of the blood vessels. As for inflammation, the most important group, optic neuritis. As for the tumors, optic glioma and meningioma, and diseases of the blood vessels, ischemic optica neuropathy. We should discuss a bit later all these diseases, but all diseases have specific changes of the optic nerve, and in all these diseases we can see the same signs and symptoms. For all diseases of the optic nerve, we can see decreases of visual acuity, visual field defects, many types. It may be central scotomas, paracentral scotomas, or disorders of the peripheral visual field. Decrease of papillary light reaction, and we can see the changes in color vision. we start to speak about optic neuritis. Optic neuritis is inflammatory diseases of the optic nerve. The optic neuritis characterized by sudden loss or decrease of vision, associated with ocular pain and dyschromatopsia. We should discuss etiology of the optic neuritis. I would like to tell you that the most common cause of optic neuritis is multiple sclerosis. If you see optic neuritis, you should exactly send this patient to neurologist to diagnose these diseases. More rare, the cause of the optic neuritis may be inflammatory disorders of the brain, inflammatory disorders of the eye and orbit, inflammatory disorders of the paranasal sinuses, systemic collagen vascular diseases, different toxic action. Optic neuritis may be idiopathic. Acute and chronic inflammation, systemic inflammation like viral and bacterial, may be also the cause of optic neuritis. But not forget that most often we can see optic neuritis in multiple sclerosis. This is severe condition, not just of the eye, but of the whole body of the patient, and rather often the first complaint of the patient may be the decrease of visual acuity, and that's why our early diagnostic and treatment is very essential. When we examine the patient, we should examine, of course, the disc of the optic nerve. This is the picture of ophthalmoscopy, which we usually can see during ophthalmoscopy. And what we can see? We can see retrobulbar neuritis or papillitis. Papillitis, inflammation of the optic disc, optic nerve head. This condition usually unilateral. In the case of papillitis, patient complains on sudden progressive visual loss. Visual field shows central or paracentral defects. Also, we can see the changes in color vision, red-green defects. When we make ophthalmoscopy, we can see a hyperemia of the disc and blurring of the margins of the optic disc, of the borders of the optic disc. Disc become edematosis. We can see swelling of the optic disc, and we can see the dilatation of the veins. In some cases, we can see hemorrhage in the optic nerve, in the optic disc. When we examine the patient using the slit lamp, we can see inflammatory cells in vitreous body. When we see the patient with papillitis, we should differentiate this condition with papilla edema. I'll explain you how to do this a bit later. As for retrobulbar neuritis, This is inflammation of the optic nerve behind the eyeball. During examination, we can see the normal optic nerve head and retinal nerve fiber layer. Exactly this neuritis, retrobulbar neuritis, rather often associated with multiple sclerosis. But clinical features, except fundus changes, are similar to the papillitis. Decreased visual acuity, changes in a visual field, and ocular pain. As for the treatment of the optic neuritis, of course, we should start from etiological treatment. Corticosteroids systemically or retrobulbar injection are essential. Antibiotics, if we know etiology and we know that these are bacteria. Of course, for the protection of the optic nerve, we should prescribe vitamins group C and B. Another way of treatment, dehydration and desintoxication. Okay, as for the optic neuritis, I hope it's more or less understandable. Now we should go further. We should discuss papillar edema. Papillar edema is defined as swelling of the optic nerve head secondary to rise intracranial pressure. The causes of papillar edema may be rather different. Usually it's a lesion in the brain, including intracranial hemorrhage, brain tumors, abscess. In some cases, it may be blockage of vertical system by congenital or acquired lesions, obstruction of cerebrospinal fluid, intracranial hypertension, severe hypertension or severe arterial hypertension, and rather rare, it may be the cause of hypersecretion of cerebrospinal fluid. So usually, if you see the patient with a papillar edema, you should think about intracranial pathology, stroke, tumor, severe arterial hypertension, and send this patient, of course, to neurologist, neurosurgeon, or GP. Look on these pictures. This is the pictures of the fundus of the eye with the papillar edema. You see the optic nerve head, edematosis, veins are dilatated. Papillar edema is always bilateral, affected both eyes. And patients usually give a history of recurrent attack of transient blurred vision. Visual acuity in early cases usually normal. Visual acuity usually decrease in later stages of papillar edema. And usually the patients have symptoms associated with rise intracranial pressure, like headache, nausea, vomiting, high blood pressure. We can classify papillar edema in 4 stages. Early stage, usually, as I have already mentioned, visual symptoms are absent and visual acuity is rather normal. When we make ophthalmoscopy, the optic nerve head show hyperemia, blurring of disc margins, and absence of spontaneous venous pulsation. Next stage, second stage, is established stage. In this stage, patient may be also asymptomatic or complains of transient visual obscuration lasting few seconds. During ophthalmoscopy, we see edema of the optic nerve head, and we can't see the margins or borders of the optic nerve head. And not just optic disc is affected, but also the macula may be affected. The third stage is a chronic stage. On this stage, we can see the constriction of peripheral visual fields, and the patient can complain on blind spot in front of the eye. And during ophthalmoscopy, we can see hemorrhages, but edema slowly resolves. Atrophic stage. In this stage, the patient usually complains on bad visual function. Visual acuity is decreased. We can find the visual field defects, severe visual field defects, but during ophthalmoscopy, we don't see the severe edema, but we see the pale white optic nerve. We call this atrophy of the disc of the optic nerve. Other signs of papilla edema. The papillary reaction are normal. The color vision may be affected in late stages. And visual field defect start from the blind spot, and in the last stages we can see constriction of peripheral visual fields. I have already mentioned that it's very important to differentiate papillitis and papilla edema. On this chart you can see how can we differentiate papillitis and papilla edema. Usually papillitis unilateral and affected one eye. Papilla edema usually affected both eyes. As for the beginning, papillitis is an acute sudden loss of vision. Papilla edema is a slowly process. If we speak about swelling of the disc, optic disc, in papillitis, swelling moderate, in papilla edema, very severe. As for the visual field defects, for the papillitis, we can find central defects, and for the papilla edema, we can see most often peripheral visual field defect. And In severe papillitis, in vitreous body, we can see opacities, inflammatory cells, but in a papilla edema, vitreous body will be clear. So it's rather often we see such patient, and rather often we have to make this differentiation. And I hope this chart will help you to make a proper diagnostic. Let's go further. Now we should discuss the most important diseases of the retina. Of course, during our lecture, we can't discuss all retinal diseases, but I think you should have general imagination. So the retina is a third layer of the eye, and it's derived from neuroectoderm. Retina can be divided into four lower regions: macular area and peripheral area. On this chart, on this picture, you can see clearly what we see during ophthalmoscopy. We see optic disc. We have already discussed this, and this is retina. We can see macular area, the exactly center of the macular fovea. We can see vessels, vein, and arteries. Diseases of the retina we can divide on four big groups. Retinal manifestation of systemic diseases, like changes in retina in the case of diabetes mellitus, arterial hypertension, renal diseases. But about these diseases, we will speak in other lectures when we will discuss systemic changes of the eye in systemic diseases. Inflammatory diseases, dystrophies and degeneration of the retina, tumors of the retina. Inflammatory diseases of the retina we will also discuss in a lecture in which we discuss inflammatory diseases of the eye. Today we should discuss in this lecture just dystrophies and degeneration of the retina, and some words I will tell you about tumors of the retina. The main complaints of the patient with the retina diseases are decreasing of the central and peripheral vision. Patient can complain on different defects in central vision, like blind spots. The patient may complain on special changes of the shape of the letters in reading, for example. When we suspect diseases of the retina, we should make special examination. Usually, we should check visual acuity, visual field. We should test color vision, dark adaptation. Of course, we make ophthalmoscopy. The essential method of diagnostic of retina diseases is fluorescent angiography and optic coherent tomography. On this picture, you can see the picture of the retina, just photo of the retina. This is also photo of the retina but without red color. But here you can see the fluorescent angiography. This is the normal vessels and normal retina, but in this case you can see changes directly in the macular area. This is age-related macular degeneration. We will discuss it a bit later. So, at first, a disease in which I would like to pay your attention, age-related macular degeneration. This is one of the most important cause of visual disability in a European country. This progressive degeneration of macular area in elderly people. You know that our population becomes more older and older. That's why these diseases we can see also more often. Age-related macular degeneration is the most frequent cause of blindness beyond the age of 35. As for the pathogenesis, drusen develop in the retinal pigment epithelium due to the accumulation of metabolic products. We get divided age-related macular degeneration on two types, dry and wet. In dry age-related macular degeneration, during examination we can see drusen in macular area, pigment epithelium, retina epithelium changes like atrophy, hyperplasia. In wet type of age-related macular degeneration, we can see choroidal neovascularization and severe edema. As for the signs and symptoms, as for the complaints of the patient, patients usually complain on decrease of visual acuity, especially when macular edema is present. Patient complains of metamorphopsia, macropsia, micropsia, and patient usually had problem in reading. On this picture, you can see the examples of wet or exudative age-related macular degeneration. Here on this chart, you can see the example how neovascularization appear. At first, new vessels from choroid, and these vessels, these are abnormal vessels, and these vessels give edema and hemorrhage. Look at this picture. You can see this is dark. It's a new vascularization. This is hemorrhages. In this picture, you can see great hemorrhages directly in the center of the macular area, directly in the center of the retina. And of course, you can imagine that visual acuity of this patient is rather low. Treatment of the age-related macular degeneration is rather difficult, and as for the dry form, we can just prescribe different nutrition components like vitamin C, E, lutein, and so on. For the wet age-related macular degeneration, we can special treatment. We can use different lasers to burn this membrane, subretinal neovascularization. But if this membrane is directly in the center, we can't use laser because we can hurt the normal retina. Nowadays, more and more often, we use intravitreal injection of anti-VEGF medicine. This anti-VEGF medicine reduce amount of vascular endothelial growth factors, and in this, when we use this medicine, we decrease neovascularization. But we should make this injection directly in the witness body every month during 1 year. Okay, so we go further, and I would like to tell some words about peripheral retinal degeneration. Some of this degeneration harmless, and we can see just atrophic changes in the peripheral retina. These changes are not dangerous, and these changes don't affect visual function. But some peripheral degeneration, like a snail track or lattice degeneration, are dangerous and may be the cause of retinal detachment. That's why these degeneration should be diagnostic in time, and for the retinal detachment prophylactic, we should use laser coagulation of these dystrophic areas. I have already mentioned that some peripheral degeneration with the breaks may be the cause of retinal detachment. On this picture, you can see the retinal break, and through this retinal break, fluid comes between neurosensory layer and retinal pigment epithelium, and we receive retinal detachment. Retinal detachment is a severe condition, and if we don't operate such patient, and the patient loses his visual functions. Retinal detachment, the most important risk factors, it's age, history of posterior vitreous detachment, myopia, trauma, diabetic retinopathy, and cataract surgery. On this picture, you can see the break and retinal detachment. Signs and symptoms of retinal detachment. Usually, patient complains on black curtain coming down over visual field. Sometimes the patient can complain on photopsia, increase in different floaters, decreased visual acuity of course, and metamorphopsia. Treatment, as I have already mentioned, should be as early as possible. There are some methods: external conventional approach and internal vitreoretinal surgery. I would like you to say some words about tumors of the retina. The most dangerous and often retinoblastoma. It's a congenital malignant tumor, usually affected newborns, and usually it's familiar cases or sporadic cases as a result of mutation. Clinical features of retinoblastoma. Retinoblastoma may be divided into 2 stages. Usually recognized at birth or between 1 to 2 years. Usually parents see the yellowish white papillary reflex. On this picture, you can see it's a normal eye. It's an eye with a retinoblastoma, yellow pupil, and in this case, parents come to a doctor very quickly. During ophthalmoscopy, tumors like a pilloid mass, white or pink in color. There may be multiple growths into the vitreous body. The last stage is the glaucomatosis stage. This stage characterized by severe pain, redness, watering. Eyeball is increased in size. And of course, in this stage, intraocular pressure is raised. Stage of ocular extension, the globe blows through the sclera, and there is a stage of distant metastasis, lymphatic spread, direct external metastasis by blood. So this tumor is dangerous not for the visual but also for the life of the children. Treatment is rather difficult. We can use cryotherapy, photocoagulation, brachytherapy, chemotherapy, and enucleation to remove eye, or even exenteration, where we should remove not just an eye but all contents of the orbit. Okay, thank you very much for your attention. I hope to see you in our practical classes, and good luck.